Thank you, Nigel. So good morning, everybody. Really nice to see you all. I'm Juliet Bouverie, so I'm wearing two hats today. I'm Chief Executive of the Stroke Association, and we're a charity that advocates for stroke survivors and supports stroke survivors' recoveries. But I'm also chair of the Richmond Group of Charities, which is a coalition of 15 health and care charities in England that advocate for people with long-term conditions, often multiple long-term conditions. So I'm delighted to chair this session, and we've got a brilliant panel who are going to introduce themselves in due course, but we've got really good perspectives from Nuffield Trust, NHS, local government and Homecare providers. But I just wanted to say, I'm feeling a bit inadequate as a session chair, I'll be honest with you. One, I don't have a fancy poll. And I thought the end of life care poll yesterday was so great. And I was like, I had poll envy, so sorry, there's no fancy poll. Secondly, this session is all about continuing NHS continuing healthcare budgets. And it's not a policy topic I know a huge amount about. So I did try and wriggle out of the session, but Nuffield Trust were having none of it. But I have now done my research, so I think I'm a little bit better informed. But it's not something I know much about. And I suspect for some of you in the room, you may not be experts on continuing healthcare budgets either. So Rachel is going to set the scene and tell us all about it. And thirdly, I think this session has the potential to be rather depressing. Because CHC really highlights some of the kind of weaknesses in the system in terms of health and social care not being joined up. And we all know that social care reform isn't coming any day soon. So I'm going to let us all get depressed and outraged and cross and all the rest of it. But I am also going to try and guide us to some solutions, because I think there are some interim solutions that we can make to make the best of what is a very difficult, complex system. So as I said, Rachel's going to tell you what CHC is, but basically it's an NHS budget which is supposed to provide fully funded health and social care for those with a primary healthcare need. Now, I think part of the problem is how do you define primary healthcare need? And I think it was set up with really good intent, but it has become mired in all sorts of problems. You know, patients and families don't know about CHC, find it incredibly difficult to understand the process. There is huge variability in the quality, eligibility and the quality of the assessments and the decisions that are made. There is confusion about the sort of standard way of accessing CHC or the fast-track way. Funding constraints are playing out in terms of the decision-making all the time. You've got the massive gulf between health and social care. And then there's a real workforce question here too, because I think it's become clear to me from the conversations that I've had with people that actually the CHC teams and the CHC assessors are not valued. They're not supported. They're not trained. They're under incredible pressure to keep to budgets. And so I think there's something about how do we best support them in a very difficult system. So I think this is going to be a bit of a canary in the mine. I hope that CHC is going to help to highlight some of the wider system challenges, but also opportunities for improvement that we have. For any of you who are interested in finding out more, I do just want to refer to a fantastic report from Age UK. Paul Farmer is Chief Executive of Age UK at the back. So if any of you have any complaints about this report, you can direct them to Paul. But it was published in December last year, and it's called Continuing to Care, Older People Let Down by NHS Continuing Health Care. And Age UK have done some absolutely fantastic research to understand patients and families' experiencing of accessing CHC. Now, I said I wouldn't take the tone down, but actually I'm just going to quote from this report. There are a huge number of quotes I could have chosen, but I've restricted myself to 3, and I think they probably do quite adequately highlight the problems that patients and families experience. So the first quote goes as follows. Several reviews for CHC during her 8-year stay in a nursing home, during the last 5 of which she needed continuous and all personal care. She fulfilled all published criteria for CHC, but was always denied it. No reason given officially, but told because the budget was insufficient. The whole aspect was time-consuming and a total farce. Dad was also 3 years in the residential home with progressive dementia to his death in 2017. Between them, they spent over £300,000 on savings, pension income, sale of residence on their care. I think that is a familiar story. Second quote is, having my mother assessed for CHC was initially and continues to be difficult, time-consuming, and to be honest, belittling. They forget to include me in meetings, don't send me letters about the outcomes of reviews. It's the only part of the NHS I consider to be unfit for purpose. And then a third quote, had someone in nursing home who finally got CHC after years of pushing. 5 years later, the decision was overturned. He'd not improved. He was older, he was frailer, he had the beginnings of dementia, he'd had 4 strokes, a heart attack, he had diabetes, hundreds of chest and urine infections. We appealed and appealed and appealed, but he died before the final appeal was decided. I mean, these are heartbreaking stories, and I'm sure many of you in the room hear about these heartbreaking stories every single day. So I think we really do need to look at how we can improve the current system. So I'm going to hand over to Rachel, who's done a really interesting piece of research to tell us about all the data and evidence behind CHC.
Thank you so much, Juliet, and thank you everybody for coming to this session today. So, my name is Rachel Hutchings. I'm a fellow at the Nuffield Trust, and I've been leading the work that we've been doing around NHS Continuing Health Care. And in this presentation, I'm going to tell you a little bit more about what it is, why it matters, although I think the quotes that Juliet has set out really show that really clearly, why we at the Nuffield Trust wanted to do the research, and a bit about what we've done so far, some of the key trends, and also some really kind of significant questions that this raises about kind of wider health and social care. So, firstly, what is NHS Continuing Health Care? So, as Juliet has already set out, it's a package of health and social care provided outside of hospital, for example, in a person's own home or in a care home, which is arranged and funded by the NHS. So it could include accommodation costs, all of the health and care costs. It's for individuals over 18 who've been assessed as having significant ongoing health and care needs that arise from a primary health need. Obviously, what that means in practice is quite difficult to determine, but essentially, it's where somebody's main need is for healthcare rather than social care, so going beyond what a local authority might be expected to provide. And it's determined by an assessment which looks at the nature, intensity, complexity, or unpredictability of a person's needs across 12 domains, such as mobility, communication, and nutrition. And as you can probably imagine, how you determine that is very complex, so I'm not going to go into too much detail about the process, but just to emphasise that it's looking at the totality of a person's needs and kind of what is needed to address those. And as we've sort of already touched on, I think some of the quotes highlight, actually in practice, that can be quite difficult to determine and seem quite arbitrary what the outcome is. So there are 2 types, standard and fast track. Fast track is for people whose condition is rapidly deteriorating, many of whom may be approaching the end of life, and actually Libby mentioned CHC in the presentation yesterday. So if somebody is eligible for CHC, the ICB is legally responsible for paying all of the health and social care costs associated with their needs. As I mentioned, that could include accommodation. So unlike local authority funded care, it's not means tested. And as is probably unsurprising, spending on CHC has also increased over time. If somebody is not eligible, they may be able to get something called NHS funded nursing care, which is where the NHS will pay for the nursing component if someone's in a nursing home. But otherwise, the costs are borne by the individual or the local authority if they fall below that means test. So what I really want to get across is that the stakes are really high. If somebody is ineligible for CHC, they're potentially facing really significant costs for the care that they need. And I think that highlights the kind of real sort of all or nothing approach that our system kind of currently takes around that. And there is a national framework which sets out the principles and processes around CHC. So what have we done on the topic? So it's part of our broader programme of work on social care. We've done a lot of work over the last few years around what's needed from reform, whether that's funding or provider market. And when we started looking at CHC, we really saw that it was a microcosm of all of the complexity, all of the challenges that we see in many areas. So we really wanted to take a closer look at it. It's complex, it's often overlooked, it's poorly understood, and yet it's really emblematic of so many bigger issues which relate to how our system separates health from social care, whether that's from the funding streams or the assessment of need, and what the consequences are for people who need support. So we began by publishing an explainer on our website, which is the picture on the right, called Falling Through the Gaps, which was an initial look at some of these issues. And as I say, when we started researching it, actually we found we really wanted to take a much closer look. So we followed that up with phase 2, which has been a mixed methods project, part funded by the Nuffield Foundation, which is set out to understand a bit more about inequalities and variation in particular, and I'll talk about that a bit more in a second, but more broadly just enabled us to take a bit of a deeper look at what's happening at a local level. So we're just coming to the end of this work now, and we're planning to publish later on in spring, but I'm going to use the presentation to just share some top-level insights from this ongoing work. So, data is captured and reported quarterly by NHS England on things like the number of CHC assessments which are taking place and the numbers of people who are eligible at a given point in time for both standard and fast track. And the first point to note, which you can see on the slide, is that overall there's been a fall in the number of people assessed as eligible for CHC since data was first collected in 2017, and that's the green line there. So people are constantly being assessed, so the numbers do change frequently, but at the end of December last year, the total number of people in receipt of CHC was just over 52,000, and that's a fall of just over 9% from June 2017. But increasingly, an increasing proportion of those people eligible are for fast-track CHC, so that's people whose condition is rapidly deteriorating, maybe approaching the end of life. And I think that kind of change in the proportion raises some interesting questions which we can perhaps cover in the discussion as well. But looking more closely, this chart shows that there's huge variation across the country. So this is looking at data at an ICB level. It's also available at sub-ICB. And you can see that there's huge variation in terms of the numbers of people eligible for CHC. So this is looking at the numbers per 50,000 of the population. And for standard CHC, this shows overall, but for standard CHC in particular, there's a range of between 10 per 50,000 and 67 per 50,000 in the highest and lowest rates of CHC across the country. So really kind of stark variation. The number of assessments that result in eligibility has also fallen over time. So the grey line on this chart shows the assessment conversion rate, which, as I mentioned, is the number of assessments that result in somebody being eligible for standard CHC. And between October and December last year, around 19% of people assessed were found eligible, compared to 31% in April to June 2017. And the green line refers to the referral conversion rate, which you can see has also fallen. And I should just point out the kind of spikes refer to the start of the COVID-19 pandemic, when assessments were paused for a bit, so that explains that line there. And again, interesting questions there about what's leading to that fall in that assessment rate, which I hope we can also discuss later. So, as noted earlier, CHC is a bit of a microcosm of issues, and it raises a number of questions. And from our perspective, we've seen that CHC can really act as a kind of window in some of the most complex issues facing health and care. So it exists at the interface kind of between health and social care, requires collaboration between NHS and local government and other partners in the system, but it's operating within a really complex environment of kind of different funding structures, but also the impact of funding pressures, different accountability mechanisms, alongside increasing complexity and need. And the data we've presented today, I think, raises a few specific questions. So, as I noted, spending on CHC has increased, and it's a significant cost for ICBs, but the numbers of people eligible is falling, which begs the question of what's driving that increase in spend. So potentially we're seeing an increase in cost of care, more complex care packages. The recent King's Fund Social Care 360 report found a similar pattern in local authority funded care and found that local authorities were needing to pay higher fees for care in part due to staffing costs, but at the same time were supporting a smaller number of people. Secondly, why is there so much variation? Well, this is undeniably complex and multifaceted, and this is one of the questions we were really keen to understand in the phase 2 bit of our work. And unsurprisingly, we heard a lot of different reasons about people's perspective of what's driving that. But I think there's real concern and anxiety that it's not just due to differences in need, but it's due to the influence of things like the financial pressures that are being faced within the system, which are influencing how the framework's being applied, how those assessments are being done, and the numbers of people being eligible. And in the 2024 ADASS Spring Survey, there were a number of questions on CHC, but one of them showed that 95% of directors agreed that they were seeing the tightening of interpretation of eligibility for CHC, meaning more placements and their costs were being transferred to councils or self-funders, which I think gives you another sense of that financial context. So thirdly, who is accessing CHC and who isn't? So I noted that the consequences of ineligibility are really significant, and this is a really important issue. But we know that there are long-standing issues raised about the assessment process, which again, Juliet, the quotes really highlighted. There's often a lack of family or specialist involvement. The assessment's supposed to be done by a multidisciplinary team. This often doesn't happen. Awareness and understanding about CHC is really low, and it often comes as a big surprise to people that this even exists, and obviously going through that process is really challenging. And also concern about how the framework, how that assessment of primary health need applies to people with different conditions, for example, such as dementia or kind of interaction between different conditions. At the moment, the data that I presented is not currently reported by things like age, ethnicity, or gender, or diagnosis. There is a data set that's being rolled out, which should hope to capture some of that information in the future. But in the meantime, there's real concerns about who is accessing CHC and who is less likely to kind of almost fight for it, really. It's one of those things where you really see that's kind of what's required. So, as I mentioned, CHC is a way into exploring some of these bigger issues, and I think what's been really interesting about the last couple of days' sessions is actually a lot of the things have come up in the previous discussion. So we've talked a lot about the shift from hospital to community. Well, everybody receiving CHC is being supported in the community, so it raises a lot of questions about that. Highlights the real importance of local relationships and collaboration. And I think it was really interesting yesterday that somebody described end-of-life care as being a really good kind of case study for integration. Actually, that's something that people have said a lot in the work that we've done, that it's almost a temperature check on integration. And if CHC is working badly, it can actually damage efforts to kind of improve relationships more broadly. But we know there are tensions and challenges in practice. I know I've set out a number of challenges. I do also want to emphasise there are areas of good practice as well, which, again, I hope we'll talk about in the panel, where things are working really well, and I think there's real opportunity to kind of spread that. But I think more broadly, it raises this bigger question of how do we provide care for people who need it outside of hospital? How do we fund that? Is the current system kind of set up to deal with that? Which I hope we can get into in the discussion. But yeah, thank you for listening.
Well done, Rachel. That was just brilliant. Set the scene beautifully. So I'm now going to hand over to our panel, who are just going to give some opening remarks. Then I'm going to ask the panel a couple of questions, and then I'm going to go to the floor because I'm conscious there's probably some fantastic experience and expertise in this room. So I'm going to let the panel introduce themselves. So David, do you want to kick off with your key reflections?
David Oliver. I've been a consultant geriatrician and general medicine consultant for about 28 years now, and I was a junior doctor all the way through the 90s. But I was also the National Clinical Director for older people in the Department of Health Social Care Division at the time of DILNOT and the Care Act, and a lot of work about delayed transfers. So I've lived with this policy area as well as my clinical day job, and I've gone through the era where all the long stay wards were closed down, where care was shifted to the community, and I have watched the criteria get tighter and tighter and tighter for access. When I started out, basically if the clinical team thought that people had complex needs, that was good enough. And I don't know how many of you have seen the decision support tool and the screening tool with 12 domains and 3 or 4 levels of need. It's inordinately complex. And I just want you to reflect on what we're doing to people here. We talk the language, don't we? Value statements about person-centered care. What we actually do is people at a level of very high need and very uncertainty, we put them and their carers through a bureaucratic, clunky process that even health professionals struggle to understand, let alone them. There's lots of sources about this, Age UK, National Audit Office, Public Accounts Committee, but Continuing Health Care Alliance concluded that people have a lack of awareness and information about the process. They have a lack of involvement, and you're supposed to involve the person and their families, but often it doesn't happen, and big delays in the processes. You will have seen there on Rachel's slides, fast track is a different beast. Fast track decisions are made by clinicians who are directly looking after the patients, and they're made quickly, and it works. But this has become more and more removed, the slow track, from the people who are with the person day in, day out, through a bureaucratic grinder. And if you try to explain the process to a lay person in plain language, Age UK have got a really good explainer. It runs to 38 pages of good plain English information. Yeah. So I don't think we're actually treating people well. And really the historical divisions between what counts as health and social are completely arbitrary, accident of history, backed up by the Cochrane ruling in 1999. I would love to see, with health and social care reform, the distinction swept away, and instead of continuing, what is it now, continuing care framework, I would change that to CCF, care comes first, because at the moment the care often comes last. We argue about money. And the final thing I'd say is, if we're serious about integrated care boards being joint entities between local government and the NHS and potential for pool budgets and joint working, this is a real test bed. It's about 4.3 billion of spend on continuing care. If we can't get this right, then we can't get much in the way of integrated working right.
Yeah, great points, David. I think that really does highlight a lot of the challenges. So, Jane.
Thank you, and thank you very much for inviting me. I'm Jane Townson, Chief Executive of the Homecare Association. We represent and support over 2,200 providers of care in people's own homes across the UK. About 25% of the total income in the home care sector comes from NHS funding. That's a combination of discharge from hospital. Some of that's paid for by local authorities, and that varies according to different places. The standard CHC and the fast track CHC that David and Rebecca have mentioned. Nowadays we can support people with really complex needs in their own homes. And those people should receive appropriate care at home if we can. But as everybody else has pointed out, there are multiple issues. I wanted to highlight 3, which just reinforce some of the things that have been said. What we see as systemic ageism. Yesterday we were talking about racism, but our members report that the CHC system disproportionately affects older adults receiving home care. So they're routinely asked about their finances, which you wouldn't do with a younger person. People who are providers who are supporting people with dementia report that despite their care needs being actually quite similar in many ways to somebody who is younger with other kinds of disabilities, older adults are frequently denied funding. Some of the care funding for younger adults runs into £4,000 or £5,000 a week. Well, dream on in care. And I think misapplication of the criteria. David's talked about the complexity of it, and Rebecca talked about the lack of training and understanding. And I think those factors make that consistency of application really, really difficult. But and then this has the delays that were mentioned have a real life impact on people, because if you're a home care provider supporting somebody and you don't know whether there's going to be funding for this care, what do you do in the meantime while someone's making a decision? Do you take a risk and carry on, you increase the care that you provide, which you might not get paid for, or do you just leave them with 2 15-minute calls a day, which isn't enough? Yesterday we talked about end-of-life care. So there are some real practical difficulties. And then the last thing I want to talk about, which really affects us in home care, is payment issues and the impact on safety, quality and sustainability. So because everybody is strapped for cash, we understand the budgetary situation, but what's happening is that ICBs think that, well, they are driving prices down to like 16, 17 pounds an hour. Now, if you take the minimum wage from April, which will be £12.21, and you add on statutory pension, national insurance, holiday pay, sick pay, travel time, training time, that comes to an average of £22.71. So that's just direct staff costs before you've even contributed to the other running costs. And the other running costs are like you have to have a registered manager, you have to pay your fees to the Care Quality Commission, you have to have insurance, you have to have an office, you have to have IT and telephony and keep records and all of these things. By paying 16, 17 pounds an hour, public bodies are creating the conditions for labour exploitation, unsafe care, and this is going to become even more serious because we're approaching the Employment Rights Bill, heading down the track like a freight train. And to make things even worse, we've had a budget that's increased costs by 10%. Many ICBs, when we did some research last summer, 75% of ICBs had not communicated with providers about fee rates. And the national minimum wage went up by 9.8% last April, and we've got a 10% increase in costs. And many providers are still operating on 2023 fee rates. And then 83% of providers are reporting that they're not paid on time. Some of them are waiting over a year for payments, which, like NHS Trust can't go bust, but 85% of care providers are small and medium enterprises with fewer than 50 employees, and we cannot cope with that kind of cash flow issue. So we want to see reform that recognises the critical role that home care can play, and eliminates age discrimination, and creates a system that values safety and quality over cost containment, although we appreciate the fiscal environment that we're in.
Yeah, I mean, fantastic comments, Jane. I came into this session feeling depressed. I'm now even more depressed, but it's really good to have that reality so clearly explained. Thank you, Jane. And then finally, Jess.
Hi, I'm Jess McGregor. I'm the Vice President of ADASS, which is the Association of Directors of Adult Social Services, and I'm a Director of Adult Social Care in Camden in London. I mean, colleagues on the panel have rehearsed the many challenges with continuing healthcare. I guess I want to focus on the thing that has been of particular concern to local government over the last probably 5 or 6 years. And that is the change we're seeing in the numbers of people who are eligible. So, and apologies, I've got a sore throat today. At a time when our population is growing and we are all experiencing across health and social care greater levels of acuity and complexity, we're seeing the numbers of people who are assessed as eligible for continuing healthcare falling. And we're seeing an increase in the numbers of people who are reassessed and found to be no longer eligible. And those changes aren't marginal. So I think Rachel was saying that that's about a 9% reduction nationally. Over the same period of time in London, that's been more than 20%. And so I guess in terms of the impact, there is definitely an impact on local government. As Rachel said, directors across the country are really clear that they are seeing more people drawing on local government funded adult social care as a result of reductions in continuing healthcare. We're seeing more complexity and acuity. We're funding larger packages of care than we ever have before, and more people are being supported by 2 carers at a time as opposed to 1. But I think the impact on people is arguably the most important. And actually, drawing on my own personal experience, 2 friends of mine who have died in the same period of time experienced changes to their continuing healthcare at the end of their life, which was really distressing. So a 19-year-old who had had profound and multiple disabilities his whole life, was entirely dependent on care from other people and his family. In his last months of life, his his continuing health care review led to a decision to massively reduce the amount of funded care, the rationale being that he'd had fewer hospital admissions than he had had previously, and fewer crises meant that his needs had reduced. And of course, the reason why he'd had continuing healthcare put in place in the first place was to prevent hospital admissions. And secondly, a friend in her 90s who was on fast-track continuing healthcare because of cancer, 3 weeks prior to her death, was reassessed as no longer being eligible. And it was explained to her that that's because she had not died as soon as it had been anticipated that she would be. And I think kind of the overriding memory for me is the incredible fear of the family members, kind of my friends supporting them, fear about what would be affordable, fear about the kind of safety and care by which those people would be looked after, fear about, would they be able to, the carers, the paid carers who had been supporting both of them were part of the family, would they be able to continue to provide care? And then a huge diversion at the end of their life with attention on trying to understand the framework, trying to understand the legal complexity, getting into a dispute with the Integrated Care Board. And so for me, the kind of overriding reflection is, I guess it's a question. I'm curious about, is there something about the financial state of health and social care, the NHS? We've rehearsed many times in the last 2 days how difficult it is to move resource out of hospital, out of secondary care. Actually, are we taking resource away from the people that it's easiest to take resource away from, and arguably those with the least power and the most to lose? And in the context of our discussions yesterday on racism, Jane's point on ageism, and Rachel's point on the lack of data, I'd be astounded if it wasn't those with the least power, the already mostly disadvantaged, excluded and oppressed, who are at the receiving end of that. And I think it's something we should all be very worried about.
Yeah, thank you, Jess. Now I can feel the shock, frustration, anger and emotion in the room, and this may be a bit triggering for some of you who've had family members who've tried to access CHC. So I'm just going to ask the panel 2 quick questions, and then I'm going to come to the audience, if that's all right. So, and we've majored a lot on some of the challenges, haven't we, which are complex and multifaceted. But do you have experience of where things are working well? Do you have any examples of good practice which might lighten the mood a little bit? Rachel?
Yeah, no, absolutely. So the phase 2 work that I mentioned, we've been doing a bit more of a deep dive into this issue and speaking to people working in CHC teams in ICBs, but also in local government, care providers as well, and spoke to people with lived experience. And I think what's really challenging about CHC is that if the outcome is not eligibility, it's really difficult to have a positive experience of the process because it feels like you're fighting for it. So I think it is really challenging, but where we have heard examples is where the assessment does feel like it's a proper multidisciplinary team, the person is involved, their family, their carers, people who have specialist understanding of the condition and how it affects them. I think often people talk about, really complex or rare conditions. If somebody doesn't understand how that affects somebody, it's really difficult to sort of determine what the outcome is. So I think where that assessment process has been done well, it can be a more positive experience. I talked about it being a kind of temperature check for integration, and we heard a lot of examples actually about where there is really good communication, collaboration locally, potentially even sort of more joint commissioning arrangements. The decision around eligibility is with the ICB, but there are kind of areas where there is kind of more collaboration. That was seen as really positive. So it was less of a kind of us and them and more about that kind of collaboration. And just to pick up the point around data and kind of access, this was such a key issue that we wanted to understand. And the national data, as I say, at the moment is limited, but there are areas that are being more kind of proactive on this, and we did hear examples of places that were really proactively trying to understand within their area kind of, are there gaps, are there kind of places where we're seeing fewer referrals than we might expect. What's the reason for that? How can we kind of target training or awareness to those? So there definitely are examples of good practice, but I think it's really challenging when the kind of core bit of it is so fraught with challenge, but definitely examples of positive
that's
working.
Great. And yeah, I really get your point about where it's person-centred, where it's truly multidisciplinary, where there's genuine collaboration, it can actually work quite well. David, Jess, Jane, is there anything else you would like to say?
Fast Track works brilliantly. In my own hospital, we've got palliative care 7 days a week. They're not ageist. They see people quickly, they make decisions quickly, they support the families, they get people to where the care destination they want, and that's how it should be. For the rest of them, I've been a consultant in 2 hospitals that were dealing with numerous, as was, CCGs and PCTs. And within the existing framework, the places that I would say work well, they had a dedicated person to do the screening quickly. Yeah. They had a responsive, quick process for doing the decision support tool, MDT. They got people out of the hospital quickly and made the decision after the fact of care being provided. Yeah. And I've dealt with other places where it's very clear that things are being driven by avoiding costs. And by the way, in the data on the report, you can see that towards the last 2 months of the financial year, guess what? The spend magically tails off, and cost is a big driver. So the places where I've seen it working well for slow track is where the person's needs are really put first. And by the way, people will appeal. So if they're going to appeal about the decision, you need to give them quick access to that ability to appeal as well. Yeah. ICBs aren't well established enough yet for me to have a sense of it, because even within the ICBs, different localities behave differently. Yeah. But I think Fast Track is the template for what we should be doing. And I realise it's a much smaller financial commitment because the people are dying by definition, but all the same, it's genuinely person-centred and responsive. Yeah, it's really interesting. And I was speaking to the Stroke Association medical director about this yesterday, and she says she has to cope with loads of cases of stroke patients staying in expensive acute stroke units because they're awaiting decisions on CHC. So your point that where it works well is somebody's transferred to the right and just
place
to say
of care,
quickly, the national
follows.
Framework says that we should be making those decisions outside of hospital. Yeah. That's what it says, but there's a mismatch between what the official guidance is and how people often behave, which is people do get marooned in hospital sometimes. Yeah, which is clearly adding extra cost and burden to the system. So Jane, Jess, anything you want to say before we
I just wanted to add that I think whether something works well or not slightly depends on your point of view. So from a hospital doctor's point of view, sort of maybe getting people out quickly to a care provider is seen as success. But we hear stories where, for example, there was a husband and wife who were both being cared for by Homecare Agency A, let's say. The wife ended up in hospital, sadly came out on end-of-life care. The sensible thing would have been for Agency A to carry on supporting her, but no, NHS Fast Track decided that another provider that was a lot cheaper would do that. So now we have 2 agencies going into the same household because Agency A is still supporting the husband. Agency B is much cheaper. The care workers don't speak English, they don't understand about equipment, they don't know about assessment, they're trying to administer morphine without any training. I mean, it's like terrifying this. Luckily, in that case, there was an Agency A who did know what they were doing and reported it to safeguarding. But the emphasis is on cost. Yeah. And the only way that you can get it as cheap as £17 an hour is by cutting corners and not doing things properly. And not training people and not paying them the minimum wage. And I just don't think we should be complicit in that type of exploitation. Agree. Well said. Exactly. Jess, anything positive that you can play in? Sorry, that was my positive.
I mean, it's ripe for reform, but I think there are things that you can do to ameliorate some of the challenges, and I think I agree with colleagues already with what they've said. It's about integration. So if you're able to take an integrated approach across adult social care and the ICB around market management and brokerage and commissioning, if you're able to pool budgets, come up with funding split decisions and ensure that actually we're navigating the challenges of CHC rather than requiring people and their families to do that, you can make it work much better. Yeah.
Can I just say something though, because that business of split funding also creates issues. So another story. There was one of our providers contacted us because somebody come out with a 60% funded by the ICB, 40% by the local authority. In that case, the local authority had agreed to pay £24 an hour, but the ICB only wanted to pay 17, and the provider couldn't do it at 17 and said no. So then the ICB threatened them with safeguarding. And so you get these arguments between local authorities and ICBs because money is so tight. So I don't know whether it's better just to have an integrated pot that's called complex care, that isn't particularly owned by either party.
Yes.
Yeah, interesting. Okay, very good. Right, let's go to the audience. So I'm going to go down this bit of the rooms. So I'm going to take lady in the front first. So we'll take 3 contributors and then I'll invite the panel to respond and we'll keep going until we get to the coffee break.
Hi, Dee Thera-Chelvam. In my former role, I was Director of Quality for a community provider, social enterprise community provider, delivering children's CHC. And one of the overwhelming challenges we had was the underfunding of the budget. Block contracts in community services. Every single year, we would always go back to the ICB needing additional funding going in. And because it was not funded properly, we ended up having to use agency at double, triple, quadruple the cost because we are not having sustainable workforcing. And also, from the family perspective, they didn't have continuity of care. So we did not put that child at the centre. And I think, from my safeguarding hat and think family, the model of commissioning did not meet the needs of the areas that we had. And one of the biggest challenges we have is transition. You've got 2 separate policy models for commissioning for CHC. And probably my question to you as a panel is, what do we need to do differently to the government, to the policymakers, by why we have a children's continuing healthcare policy? We've got an adults, but that individual is crossing and they drop off a cliff. And that need is still there.
Yeah, great, thank you. Yep, we'll go to Emily. Yeah, I'll come down this side of the room, and then I'll come down the middle, and then I'll come down the side.
Thank you. I'm Emily Holtzhausen from Carers UK. I wanted to first offer a positive perspective from families that I know well, like, you know, Jess. And I've also supported a family member to go through this, and we did get it. So I'm very pleased to see that we'll get some data on age, ethnicity, because I think, you know, we've got some big structural issues on how this works. My God, it was difficult. But where I've seen for families that I've known for quite a few years is where it's community-based care, where they've had direct payments. And then when they've moved through to successfully getting continuing health care, they then get a personal budget and they're still able to effectively commission their own care within the family. And they've had continuity of workers, you know, and funnily enough, the split beforehand where services weren't integrated were better afterwards. I feel they've had, you know, I feel in the way that they talk, they've had more freedom. I think in the past we've seen ping-pongs between local authorities and health bodies, like who owns the well-being of the carer. Health bodies have tended to ping that back to local authorities, but actually the decision about the CHC funding needs to build in support for carers. I'm pleased that we've lost the term 24-hour care, because it never was. And when you say that to families, it's 24-hour care, they kind of expect 24-hour care in their own home, and it's not. So, I mean, to the panel, you know, what role for families in the future with all of this? They're the ones who have to challenge, and I'm also thinking about somebody, just another bit of anecdotal as well, a carer that I work very closely with. Her husband has a very complex degenerative condition, used to get CHC, reassessed, and hasn't got it. She appealed, but she is exhausted. And when she had CHC, her one issue was that she was not able to commission the care that she needed in the local area because of a shortage of the quality of care and the sort of interdisciplinary care, sort of the stuff that Jane's talking about, the complexity. So what role in the future for families with this, where we see this complexity of care?
Thank you, Emily. And then was there another question? So I'm going to go to Paul Farmer at the back, if you don't mind. Sorry.
Thanks, Juliet. Paul Farmer from AGK. Thank you for the plugs. Please do look at our 38-page concise guide and the 12-page very good report. I'm also a non-exec at Frimley ICB and thought it would be a good opportunity to welcome you to Frimley ICB, in case you're wondering which ICB you're in at the moment. And one of my observations from that is that this is almost one of the sole areas where, as a board, you actually see the true cost of patient care. Because lots of it is normally just clunked up into all kinds of macro spending areas. And so people beginning to understand what cost really looks like in a patient care setting. And I think that's a good thing, because we need to understand what good quality cost really looks like. My second point, and I really want to cheer you up, Juliet,
Thank you.
is that we're doing this thing called the 10-year plan, and we're trying to come up with something that helps us to get people out of hospital into the community. We want to identify ways in which we can support people with the greatest need to get the best possible care, to be treated with dignity and respect, to have that care in the place that's most appropriate to their needs, in a way that is fair and equitable. Well, hello? Here is a project that we can really learn from in terms of going into the next phase. Of course it doesn't work perfectly, as everybody's clearly identified, and that's because of the obvious fault lines that everybody in this room is all perfectly aware of. And I too, by the way, am really concerned about the lack of demographic data on this, because I think we all know that people who are good at arguing well for their case will get this, are much more likely to get this, and I think we just should acknowledge that. And I think people who find it difficult to navigate their way around the health system almost certainly don't know who get it, about its existence whatsoever. So part of the challenge, I think, here is about asking the question, who doesn't even apply?
Yeah.
Who doesn't even know about it? Who could really benefit from it? So this is a data absence problem as well as a data reality problem. So I'd love to get panel thoughts on that. And finally, I suppose the obvious question really here is, how do we reform this in a 10-year plan environment? Because there's a lot of really good stuff here, but it just isn't working. Thanks.
Okay, thank you very much. So I'm conscious of time. What I'm going to do is I'm going to ask one panel member to respond to each of the questions, because I'm keen to get to as many hands as I possibly can. So Dika's first question was around what do policymakers need to do differently? Anyone want to take that? Don't all jump at once. Rachel?
Yeah, I think thank you for raising the point about transition, because I think that even though the work that we've done has focused on over 18s and the process around that, we heard a lot of examples through the work about the disconnect between children and young people's continuing care, and that fall off a cliff is exactly the kind of phrasing that people have used. And I guess from our perspective, the work we've done, and I think we do acknowledge that a lot of this points to a need for much bigger reform around how we do sort of social care more generally, and we heard about this yesterday, like how do we do the 10-year plan in the absence of social care reform. I think it points to a need for bigger reform, but as part of that, looking at that kind of transition point and whether that split is even helpful, I'm not sure it is really. And I think one of the questions we were sort of thinking about before we came together on the panel is this idea of kind of what does the future look like, and what do we want services to be able to do in the future. And I think David alluded to this in his introduction, that CHC has come out through sort of a kind of slightly piecemeal approach, sometimes people might think, a sort of through case law, through changing context, and actually is it fit for purpose in terms of what people need now from services? One of the quotes that we heard in our work was somebody saying, well, why can't we sort of support the person and then think about how we fund it afterwards? And actually at the moment it feels like we've got it the wrong way round. So I think as part of that bigger discussion, that absolutely needs to be part of it. It's actually, what do we want the future to look like, and how do we want to support people? This kind of arbitrary primary health need or not just doesn't kind of feel right for what we have at the moment.
So given we've got an opportunity to influence the future through the 10-year plan, what do we want to advocate for? What's our recommendation for the 10-year plan? Anyone wants to answer that?
I'm going to pick up on Emily's point about carers. I know there are some organisations that sort of specialise in supporting people through this process, but I don't know whether that's enough, and whether more investment in advocacy for people for this CHC process would be a good idea.
Bear in mind, of course, that in the 2014 Care Act, there were already a load of rights for support and assessment for carers enshrined in that. But because it was never funded, in fact, we had austerity hitting local government for years it's not fully recovered from, we were not able to make those rights the reality for most people most of the time. And in the continuing healthcare assessment framework, it's very clear we should be involving, back to Emily's point, carers right from the outset in the process. So to an extent, we don't need to reinvent the wheel. We need to do what we're supposed to be. And the obstacle is resource. But bear in mind, to get NHS continuing care, unless you're dying, you have to have very, very high levels of need, right? So these people are going to need care, whoever's paying for it. That's beyond question. They're not people with the moderate social care needs. So I think, meaningful reform in the 10-year plan would, first of all, it shouldn't have excluded social care from the conversation.
Yeah.
But secondly, there's got to be sufficient resource, because if you're serious about shifting care from hospitals to the community, about the rhetoric, you have to resource those community services, don't you? And so it has to be back with the resource to make it happen.
Yep.
And the social care reform hopefully can be brought forward, because what is it now, 2029 or something we're expecting?
8.
Well, that was our big recommendation. Well, one of our big recommendations from yesterday, wasn't it? Was bring social care reform forward so it matches with the healthcare plan. Jess, very briefly, was there anything you wanted to mention?
So I guess on the 10-year plan, I think neighbourhoods presents a real opportunity, particularly if we think about neighbourhoods in the broader sense, thinking all age, whole family, intergenerational. There's an opportunity through integration to do some of this better. I think there are also opportunities through the 10-year plan to think about funding and how funding flows and the financial incentives.
Yeah.
I wonder whether there would be value in some national policy around joint funding and dispute processes, and whether that might be helpful. But I think fundamentally it needs to be at the core of the conversations around social care reform. What is care? Who pays for care? And how do we do that?
Yeah, really clear. Great. Right. Oh, my goodness me. I'm going to singularly fail to come to everyone, but I'm going to start from the front and work back. So, sorry, we've got the mic there. Yeah, great. Hi. Hello.
And I'm sorry, but I'm going to depress you again because I have a personal experience of going through the CHC process with my 91-year-old mum living with advanced dementia. My question is, does anybody know how much this machine costs? And what would happen if we took the costs out of fighting each other and actually put it into caring for people? My personal experience was, and Paul, I have to disagree with you, that people who know how to do it can do it. I know, I'm a social worker, I'm a chief executive of a hospice. It's nearly killed me. I applied for continuing health care for my mum in September 2023. I got a decision in September 2024, in part because they lost the paperwork. The answer, of course, was no. So I'm now in the appeal process, and it's a bloody good job. My partner is a manager of CHC and can help me through that process. God help everybody else. So my second question is, what would you do? I like your idea, Jane, of kind of moving it to a complex care fund, but we have to take this fighting between health and social care, leaving people distraught and underserved out of this.
Yeah, okay. I'm going to take some more questions in the middle, so come to the front, and what I might do is I'm going to change the plan. I'm going to try and get to everyone in the audience, because there's so much rich experience, and then I'm just going to invite each of you, if that's all right, to respond in the time that we've got available.
Hi, Sally Gainsbury, Nuffield Trust. I'm glad we've got round to this bit of the question because it felt a bit grubby. But in terms of if the ambition is to put more resource or to sweep the distinction between health and social care away, where do you propose the money comes from that? And please don't tell me it's going to come from savings to the NHS. It's really difficult to estimate how much free social care, for example, would cost, because we're not meeting anywhere near what we think the level of need is. But no, I'm not going to give you our final number because we've got some work in progress at the moment looking at this. But we are looking at significantly more than the entire NHS budget spent on GP primary care, and that's like the minimum estimate. So this is a huge increase in public spending. Where do you propose it comes from?
Yep, good question. Okay, any other questions?
Thank you. Neno Sudi, Chief Exec at North Mid and Trustee at the Nuffield. I really enjoy the conversation and it breaks my heart. I'm sitting here thinking about productivity as a term we apply to everything we do, often within acute settings. And there's a real question about what is the cost of the waste, both in terms of the number of applications and the number of appeals, and I wonder if that's quantified anywhere. I'm really keen to understand what was described as an assessment of affordability rather than an assessment of need, and how do we divorce those two and create true independence in terms of the assessment of one and a conversation on the other. Does that invite us to think about the footprint of decision-making on a different spectrum? Is an ICB the right size? Should it be larger? Should it be even regional? Should it be beyond that? And then I felt a glimmer of hope that Fast Track worked well. We always just try and reinvent other things. What is it that works well from that process that we could apply to the slow track process that keeps the good, magnifies and amplifies it in a better way? And that question of equity is really one that sits heavily. So I'm really a proponent of getting that data. And when I looked at the graph, and I can't remember if the graph was showing the proportion of eligibility and the variability within ICBs or the number. So there is a real question of what is the denominator there? What is the unrequested element of that? And is it necessarily that those who have higher proportions of eligibility are doing well, or just that they have fewer requests?
Yeah, great questions. Good. Yes, I come to the lady in the orange shirt.
Thank you. Sarah McClinton, the Chief Social Worker at the Department of Health and Social Care. I think the Age UK report talked about the process being the punishment, and I think we sort of heard that. But I did want to support Paul's points, really, because when I last looked at that data, the rates of continuing health care agreed were highest in places where you have highest number of self-funders in those populations. So I think it tells us quite a lot about who does get access to NHS services and some of those inequities that we know operate across other services as well. But I think what Jess was describing, and I think we just need to kind of underline the point that what we've seen is an implicit shift from what used to be, if I think across my career, what used to be seen as healthcare is very much now seen as social care. But that's been an implicit shift, not an explicit policy. And I think the policy question is a really real one that we have to grapple with as to, yes, let's take the process out of it and use that money differently. But what does that mean really in terms of who does pay for it? It brings into question things like, the NHS being free at the point of delivery. I think I'm talking more about the kind of slow stream, but actually, given where we are, what are the policy choices really in terms of how long-term care is in the future? And if it is about social care, and I think there are issues about local authorities having market-shaping responsibilities and commissioning that, but actually, should it just be, is it something that people will need to pay for in the future?
Yep, great. So I'm going to take one more question. Yep.
Thank you. I'm Becky. I'm a public health registrar who's been working on this project with Rachel and others in the team. Thank you for such interesting points and a great presentation. And I just wanted to pick up on Rachel's point and what Sarah's just mentioned and Paul was talking about with that unmet need and who might not be even getting access to those assessments in the first place. And we know that the route to CHC is often through being known to services. And, I'm another person with personal experience, as many people in this room, I'm sure, have experienced themselves. It can be a real struggle to even get access to social care. And I think that I'm just kind of curious thinking about, in our work, we've heard some really good examples of practice where ICBs have been really proactive in trying to reach people and make sure that they're aware of CHC, but I'm really curious to hear what the panel thinks about this tension between a really difficult system when you do get in it, finances being stretched to reach the need for people that we already know about versus trying to maybe reach people that don't know about it and improve that equity and access.
Great, thank you. So some really big themes there. The things that I picked up on were costs, the cost benefits of doing things more efficiently, and where's the money going to come from? That seemed to be a theme. There was stuff around data, a lot around inequities and how we address those, a question around how we learn from the fast track process and could we apply that to the standard track. A question around might some of the panels and decisions be best heard at regional rather than at ICB level, and then what are the long-term policy choices here. So I'm going to just let each of you in turn respond to whatever you want to. So I'll start with Rachel.
Oh, God. Okay. Yeah, thank you so much for all those points. I think I'll just try and touch on a couple of them. I think on the inequity, this is a big theme of the work that we're going to publish in a couple of months, so please do keep an eye out for that. It's something we've tried to unpick. As we say, the data is quite limited at the moment, but it's been interesting just hearing people's sort of anecdotal experience around what makes you more or less likely to access CHC. I think we've heard sort of generally in the conversation around it is a real fight. You have to know about it in the first place, but you also have to be willing to kind of keep fighting. We've touched a bit on the appeals process, so it might be that actually people get to that point and they just don't want to appeal because the process up to that point has been so difficult. So I think that it is a really challenging area, and I think understanding more about who is kind of getting access is really important. And the point about the link to the number of self-funders, we're really interested in the links around things like deprivation as well. So all of those things I think sort of factor into each other. I just wanted to pick up very briefly on the kind of the cost and the waste. I think one of the things we've looked at is spending from an ICB perspective on CHC, but I think, I'm not sure, and I'm going to look at Sally here, whether it would even be possible to kind of quantify the cost that comes from things like the disputes, and there's also something called previously unassessed periods of care. So if you, on appeal, it's found that you should have been eligible for a certain period of time, that funding's backdated. It's very, very complicated. There's so many different things. But I think to try and end on something positive in relation to that, I think we talk a lot about this, the anxiety that the financial pressure is affecting the kind of thresholds and the eligibility decisions. And I think it's fair to say there's definitely anxiety around that. But we did hear that actually more could be done at the commissioning stage to actually be more strategic around how services are commissioned, to actually make sure that they're being done in a more collaborative way. Jess alluded to some of these examples. So I think there are ways to address some of the kind of financial consequences that are about trying to do things differently now, rather than trying to kind of find a load of extra funding. But I think pooled budgets, looking at where those are working, if they're working across the country, trying to spread that good practice. I think there is learning that we could definitely draw on.
That's brilliant, Rachel, thank you. So can we keep I'm conscious Dadia's waving at me, ticking me off for time. So if we could just keep your remarks relatively brief.
Okay, within the existing system, there's a variation from 32% to 5% of people assessed who are converted to being eligible. There's a fourfold variation in the overall eligibility. That happens in localities that have got similar demography. There are clearly disadvantaged groups. There is clearly the issue of self-advocating middle-class people, knowing how to get some advocacy. So we need more consistency within the existing system and with the existing budgets. But in terms of futurology, when the Health Foundation did projections of a social care funding gap, even to maintain current levels of access to adult social care, you're talking an extra 8 or 9 billion a year, let alone expanding access to sweeping people with moderate needs. So that has to be a big public conversation about the funding of long-term care. And the division between what counts as health and what counts as social is entirely arbitrary, accident of history. And if we're being radical and bold, you'd sweep that away and say there's a people and they need care and their carers need support, and we should stop wrangling about who pays for it. How it's funded, that is a big public conversation, which every government has ducked in terms of, there's only about 3 solutions to funding social care. You have to pick one of them and back it. And I commend you to look at Natasha's work for the Nuffield Trust, looking at the lessons from Germany and Japan about you can have a big public conversation.
Yeah, agree. Great. Jane?
I'm interested in what they're doing in Australia and think that we should look seriously at elements of what they do. So their population is 26 million, half of England. They have one national, like if you think you need care, you log on to their national computer. So it's one portal, not 153 local authorities and 44 ICBs or whatever it is. Somebody will then assess you locally and there are different levels. Now, you could imagine in this context, CHC just being, they have 4 levels in Australia, but you could say CHC could be level 5 or, whatever, it doesn't matter. They've got public subsidies associated with each of the levels. And again, the issue of how it gets paid for is another thing. But then the individual is basically, to Emily's point, treated as though they were a self-funder or a personal budget holder. And you basically you do away with commissioning. So then the people go round and they look for the providers, or there'll be some help for them. So I think we need to do something completely different.
Yeah, interesting, Jane. Jess?
I guess I was very struck by the comments about cost and waste and fighting and dispute. And I do think we need to hold ourselves to account around that. There's an awful amount we can do together currently to reduce that. And I say that coming from a system where we haven't managed to reduce the disputes that we're currently having, but we have to keep on working at that because that will make it easier for people.
Yeah, amazing contributions. Thank you all very much. I'm not going to even try and summarise, but it does strike me that CHC is the most fantastic example of how you could redesign the system to really integrate health and social care. And instead of looking at the social care problems at a macro level, maybe we need to look at them at a micro level and use CHC as the example for what reform might be possible. So brilliant conversation. Thank you all so much, and thank you to the panel.